So good afternoon, everyone. I hope you had a nice lunch. So we will start off with the next session, which is the Early Career Investigator Forum-Podium presentations. And we have 10 presenters this afternoon. 9 of them will be presenting in person and 1 virtual presenter. So they have 10 minutes for their presentations, and there will be no live Q&A during this session. But if you have any questions for any of the presenters, please note it down. They will be available immediately after this session during the networking component, and that is during the break. So you can bring your questions to them, and they will be happy to answer those questions. Okay? So we will start off, and I would like to invite on stage Tsaone Tamuhla from South African National Bioinformatics Institute, University of the Western Cape, South Africa, to make a presentation.
Good afternoon, everyone, and thank you for that introduction. My name is Zeina Al-Mahayri, and today I'll be taking you through the steps of how we piloted the implementation of a genotype virtual African population cohort in the Western Cape province of South Africa. So it is well established that there is limited knowledge of genetic drivers of disease in African ancestry populations, and that this limited knowledge is largely driven by limited data for human genomes from sub-Saharan Africa. And while the cost of generating human genomic data have gone down significantly in sub-Saharan Africa, they still present a significant barrier to generating large enough genomic data sets that can address population level questions. So to address these disparities, our research had 3 main objectives. So the first one was to create an African resource in the form of a genotyped cohort. And this genotyped cohort would not only have African participants, but we also aim to use African-specific tools to generate the genotyping data. Secondly, we also aim to use a robust informed consent process, which would allow our cohort to grow over time. And thirdly, to ensure that our cohort was both pragmatic and cost-effective, we then piloted the use of routine health data as a way of generating phenotype data for the genotype data in our cohort. So to achieve these objectives, the study had 6 main steps. So firstly, when creating a genotype cohort, you're asking for sensitive genomic information and access to health records. So special consideration needs to be taken when interacting with the participants, especially with the consent process, to ensure that any consent given is truly informed consent. So for our genotype cohort, we opted to use the tiered informed consent model to recruit our study participants. So following consenting of participants, we then collected DNA using barcode swabs. And we use barcode swabs because they are cheaply available and they don't have like complex transportation skills and even sample collection skills. They can be done easily by the participants themselves. Additionally, we also piloted using already available samples to collect our data. And for this study, we collected DNA from the peripheral blood samples of consenting participants, which had been stored from other studies. So after doing the DNA collection, the next step was to do genotype generation. And for this, like I said, because we wanted to use African-specific resources, we then opted to do genotyping on the H3 Africa Consortium array. And then following genotyping, we then did the QC of both the samples and the SNPs in Plink and in R. And then finally, to test the feasibility of being able to use these data for a GWAS, we then did 2 pilot case studies in type 2 diabetes mellitus and in severe COVID-19 using phenotype derived from the electronic health records of consenting participants. So for our pilot study, we genotyped samples from 459 participants, and 74% of these samples passed quality control and were available for further analysis. So when assessing the samples that failed quality control, we then found out that a majority of these samples were excluded because they had excessive genotype missingness when set at a threshold of 2%. Similarly, we also genotyped 2.27 million SNPs on the A3 Africa chip with an overall core rate, genotyping core rate of 97% before quality control. After QC, 78.6% of the SNPs passed QC. And again, we assessed those SNPs that had failed QC and found that 12.6% of the SNPs were excluded as they had a man low frequency of less than 1%. And like has been said by previous speakers in this meeting, that African populations are highly heterogeneous, and the same is true for the Western Cape population. And so when we did an analysis of the population structure using principal components, we can see here our genotype cohort, that's the positive pink signs, while they do cluster with the African data from the 1,000 Genomes Project, there are also a significant proportion of them that do not cluster, which shows extensive stratification and that there's high genetic variation in our study population, as to be expected from the Western Cape province. So now when looking at the case control studies that we piloted individually, so from the 343 participants that then passed QC and were able to use their samples, we identified 93 cases of type 2 diabetes mellitus and 250 controls. And of those cases, the majority of them were female, and the cases had a median age of 57 years. What we then did was that we then looked at, because we were genotyping for the first time on the A3 Africa chip, we wanted to see, are we able to identify any known variants in our data set? So we identified 43 known variants that are associated with type 2 diabetes mellitus, and we compared the occurrence in cases versus controls. And we found 3 which were overrepresented in the cases when compared to the controls. And even though we realized that our sample size was too small for like a definitive GWAS, we still went ahead to pilot our entire process and did a GWAS anyway. And when we did the GWAS, we should be able to identify 4 variants that crossed the suggestive threshold of 10 to the minus 5. Obviously, nothing was significant as we didn't have enough of a sample size for those results. And then similarly, again, using the same 343 people that passed QC, we identified 63 cases and 280 controls with severe COVID-19. And this time for the severe COVID-19 cases, the majority of them were male and the median age was 43 years. And similarly, we also assessed the occurrence of 31 known variants, COVID-19 associated variants, and none of them were overrepresented in cases when compared to the controls. And again, similarly, we then ran a GWAS just to see what we would pick up, and we found 7 variants that crossed the suggestive threshold. And so, I mean, obviously these results don't mean anything. We need a bigger sample size to see if we'd see something similar, but it was just good to see what it would look like. So finally, the overarching aim of this research was to describe and pilot a pragmatic study design that would facilitate the implementation of a cost-effective, scalable virtual African genotype cohort that can be used to identify disease-causing variants in African populations. And we have shown that the genotype cohort design can be used successfully for both hypothesis-generating research and for hypothesis testing research. And because we're able to include severe COVID-19 as a phenotype in our pilot case control study, we've also shown that this type of research design is it's agile and can be responsive to emerging health challenges. Additionally, we've shown that the genetic and genomic analysis done with this cohort can accommodate highly heterogeneous populations with the right tools. So if you're able to stratify your population and then include that into your GWAS and control for that, then you're able to study highly heterogeneous populations. And also, the tiered-informed consent model that we used allows for participant recontact for future studies where more complex samples and data might be needed. So what this means is that unlike in other cohorts where large samples are collected and there's need for biobanking, in our study design, initially you just collect a sample by barcode swab or from an existing blood sample or genetic material. And then depending on what you find with those data, you are then able to then ask for more samples and do more complex studies. But in setting up the cohort, you do not need to have large, complex, and cost-effective biobanking facilities. Additionally, by having indefinite follow-up through routine health data access, we have also demonstrated that multiple conditions can be tested from the same cohort without needing to go back each time and recruit new participants. So as we're able to see, we could still, from the same 243 people, have COVID-19 cases and also have type 2 diabetes case without having to go out and say, we have a type 2 diabetes study, we have a COVID study, we have a da-da-da study. From the same cohort, you're able to get multiple conditions. So through this research, we have shown that the genotype cohort design can work in resource-limited settings. And what we need to do now, the next steps, is to expand the cohort size to a size where we can actually do GWAS and post-GWAS analysis that can give us definitive results. And I didn't do this work alone. I work with Prof. Nikki Tiffin and Irene Muchada, and I also like to say a special thank you to our collaborators and also to the funders for making this project possible. Thank you.
Thank you, Tsaone Tamuhla, for your great presentation. Next, I'd like to invite Emma Magavern, Queen Mary University of London, William Harvey Research Institute, UK, to give her a presentation.
Hello, and thank you so much for this opportunity to present some work that I've done with the team in the UK on British South Asian ancestry participants' views of pharmacogenomics. Now, as we've heard from lots of people today, there's not really scientific question anymore about whether genetic information can improve our efficacy and decrease toxicity of medicines use. We know it can. The question is, how do we use that information? And that's a bit trickier, I think, as all of us here as either medical providers or patients' relatives know, the clinician and researchers' concerns can sometimes not be the same as those of patients, participants, and it might be hard to anticipate in advance what the differences are. So for that reason, we thought it was really important to talk to people. And we wanted to talk to a specific group of people. So we recruited from the Genes and Health study cohort participants. And this is a large community-based genetic study in the UK, and the participants are all of Bangladeshi or Pakistani ancestry. Now, they're really, really important to talk to this population within the UK context. They're underrepresented in genomic studies and therapeutic trials, with really, unfortunately, suffering from high rates of multimorbidity leading to polypharmacy. And it's a group that generally doesn't engage so much in policy making. So our objective was to elucidate this community's perspective on pharmacogenomics. So what did we do? We held 4 focus groups with 9 to 12 participants each. One group was men only, 1 women only, and 2 of mixed gender. Simultaneous interpretation was available for Bengali and for Urdu because we know that we really miss a lot when we only communicate with people who can speak English. These focus groups were recorded, transcription was done, and thematic analysis was undertaken to learn what we could from these participants. So who were these people? There were 42 in total, over half women, a quarter born in the UK or in Europe, and about half had been born in Bangladesh and 17% in Pakistan. Over a third had reported university level education, and this was mostly outside of the UK and Europe. The primary reported spoken language was English for about half of the participants, with 36% speaking Bengali and 12% primarily speaking Urdu. So what did they have to say about clinical implementation of pharmacogenomics in the NHS context? Well, participants were really clear about the benefits. Everyone unilaterally saw the benefits and liked the idea of more tailored prescribing. But there were a lot of other aspects to discuss. So communication, people wanted to know very clearly that pharmacogenomic tests is not diagnostic, that it's different from the genetic tests they know about in clinic. It's not going to tell you if you have a disease today or if you're going to have a disease in 10 years. Once people understood that, they were really clear that they didn't want to know about genes and genetics. They just wanted to be told, this is a test that will help us to understand if a medicine is suited to you or not. That's it. They thought that trust could really be enhanced by being simple, direct, and concise. They also thought that GPs were the really important people to do the communicating. Now, where to test in the clinical pathways, there was a really interesting discussion around primary versus secondary care, but also around primary versus secondary prevention. So a lot of participants said, well, why don't we get this information as soon as a baby is born, and then we can use it to make medicines better and safer for them their whole life. And no one had any concerns about testing neonates for this, it's worth saying. But a lot of people also said, well, if we can't just do everything in the first instance, why not target secondary prevention, people who are really sick already and take a lot of medicines? Now, there was really strong consensus across all groups that primary care was the place of preference to implement pharmacogenomics. People trust their GPs, they think the GPs are great at communicating, and they associate hospitals and secondary care with danger. The custodianship of data was really important. So everyone wanted healthcare providers to have access to this information at point of care, but people felt really strongly that they liked the idea of the patients having their genetic information for this purpose, because then they can self-advocate and also make sure that we minimize issues with transitioning genomic knowledge across different care settings, right? So if the information goes with the patient in their cell phone, say, from the community pharmacy to the GP to the hospital, then you don't lose that across systems. Cost was a really important consideration. People were very protective of the NHS system and really concerned that any new testing that comes in for pharmacogenomics would have to prove its worth and not risk being sort of another cost in an already resource-strained system. Trust was the critical factor here for implementation of pharmacogenomics. But there was a really interesting thing here. So one aspect was the amount and consistency of trust people expressed in their primary care providers. And this was really, really exciting, really, to see that this community had such faith in their GPs. But the other really interesting thing was that participants unilaterally said that if they were told they had had a test saying that this medicine was better suited to them or not, they thought they'd be a lot more likely to take their medicine. And compliance being a big issue that we face as clinicians, this is quite important information. Education and outreach, I think COVID highlighted for us the importance of communication media and education. And a really interesting thing that this community highlighted was intergenerational communication. So I saw some prior presenters highlight this as well, but that's what the community said. They said, go into the schools, teach the children, because all this stuff about DNA and genes, I don't think we can understand. The older generation doesn't know, but if you teach the children, they'll come home and they'll tell us in a way we understand. Now, when we transitioned to research, we said, okay, we do this clinical service, we generate pharmacogenomic information with our care system. Then everyone's going to say, can we access that information for research to make medicines better, more effective, safer? And how do you feel about that? And this was a lot more nuanced, people's responses. So they immediately saw the benefit to the community of representation in research and of advancing care for the community. But there were concerns around trust. A lot of concerns and potential misuse of data, and a concern that if people didn't have trust in the agency or the individual associated with research or with recruitment, then they absolutely would not want to share their data. And crucial to overcoming that barrier and that trust concern was education and outreach. And here, around research and data sharing, people felt they wanted a lot more information. So for clinical implementation, they said, we don't need to know all that genetic stuff. We just want to know if this medicine suits us. But if we then share our data, genetic data in this context for research, we want to know a lot more about it, and we want to know who's doing the research, and we not want to know why. And people need to then understand what this genetics business is all about and what the risks and benefits are. So in terms of facilitators to data sharing, the benefit to the community was a big facilitator, but also maintaining that trust was the most critical. And there were barriers which could be overcome. The barriers were around things we know well and have heard discussed a lot: privacy, confidentiality, data ownership, really important. But these could be overcome by transparency, by guidance, by information governance, and people's concerns were really around industry and private sort of financial players. So in summary, implementation of pharmacogenomics was perceived to be beneficial to individuals, but pose a risk of overburdening resource-limited systems. And research with that data was perceived to be beneficial to the community, but with concerns about data privacy and misuse. Data sharing was desirable if the researchers did not have a financial stake and benefits would be shared, but participants were really afraid of price gouging, of a scenario where industry gets access to their data and then uses it to make care unaffordable or jack up the prices of medications that the community needs. So trust was the key condition here for everything and was linked with medication compliance and education, and they formed a circular model where if you implement well a precision medicine service, then people have more trust in the medicine they're being given. And they say then they're more likely to take it in the dose and days it's prescribed. And that if people see this faith in the system, they're more likely to share their data for research. And if they do that, they see that the research base represents them. And again, if they see that this research was done in their community, they say, oh, for sure it benefits us. And they're more likely to take the medicine as prescribed. Thank you so much. Yeah.
Thank you, Emma, for that brilliant presentation. I would like to invite on stage Kathleen Wheeler from the University of Witwatersrand, South Africa, to make a presentation.
Good afternoon, everyone. My name is Caitlin Wheeler, and I'm a PhD student at the University of the Witwatersrand in Johannesburg, South Africa. Today, I will be presenting on my master's work, which looked at the impact of CYP3A5 genotype on the pharmacokinetics of tacrolimus in a South African pediatric liver transplant cohort. The standard of care for end-stage liver disease is liver transplantation. Due to pervasive shortages in deceased donors, living donor liver transplantations have been implemented in clinics. In South Africa, in 2013, the Wits Donald Gordon Medical Center initiated a living donor liver transplant program. Here, in pediatric patients, pediatric patients with end-stage liver disease are prioritized for liver transplantation. So how does living donor liver transplantation work? Firstly, the pediatric patient's liver is completely removed and replaced with a graft from the donor. This is important when considering the impact of pharmacogenomics post-transplant, which will be impacted by the donor's genotype. Despite the high success of liver transplantation, patients remain on immunosuppression schedules throughout their lives. Tacrolimus, a calcineurin inhibitor, forms the primary backbone of immunosuppression in pediatric patients at the Wits transplant unit. It is well characterized by a narrow therapeutic index and high interpatient variability. The balance of therapeutic drug levels is especially important in pediatrics, where in South Africa, poor treatment outcomes are frequently observed. Drug metabolism can be estimated using a weight-adjusted concentration dose ratio, which is shown, the formula for is shown on the slide. Pharmacogenomic research has attributed the variable interpatient pharmacogenomic variability to CYP3A5 or cytochrome P450-3A5 genotype. As you can see in the table, star 1 alleles are fully functional and are classified as expressors, whereas having a homozygous star 3 genotype is a non-expressor. Clinically, the consequences are that expressors have a low concentration dose ratio due to rapid metabolism. The Clinical Pharmacogenomics Implementation Consortium recommends an increased starting dose, up to double the recommended in expressor genotypes. However, these guidelines, which were published in 2016, have not been implemented in South African transplant units. As has been discussed at length during this conference, when thinking about how to translate genomic research into the clinical potential, it is important to consider the impact of different pharmacogenes. The pharmacogenomic impact of CYP3A5 and other pharmacogenes have been well documented for tacrolimus. However, in a South African transplant setting, no studies have been conducted. Therefore, building an evidence base for a local population is extremely important to get clinician buy-in. This will allow for the development of tools for clinical use of pharmacogenomics suitable to the clinical environment and the implementation. So for this study, we recruited patients from across South Africa who were all transplanted at the Wits University Donald Gordon Medical Center. The experimental methodology that we used restriction fragment length polymorphism analysis, similar to a study published in a kidney transplant cohort co-authored by Colette Dandara, who is sitting here in the audience. Allele frequency distribution for CYP3A5 curated by Forum-GKB varied between different populations. As you can see here, in European populations, non-expressors are the majority, where in African populations, expressors become the majority. This was replicated in our study cohort with the majority of star 1 or star 1, star 3 expressors. So when looking at the tacrolimus concentration trough dose over the first 15 days post-transplant, expressors undershoot the therapeutic range of 12 to 15 nanograms per microliter. This is clinically relevant for patients in transplant centers. When looking at the more appropriate weight-adjusted concentration dose ratio, it was seen that concentration dose ratio was significantly lower in expressor groups. We did a multivariable analysis using graft to recipient weight ratio, donor CYP3A5 genotype, and donor age, and found that graft to recipient weight ratio as well as CYP3A5 genotype was significantly associated with concentration dose ratio. So the clinical relevance of this is that CYP3A5 hepatic expressors have low tacrolimus concentration dose ratio. This makes the balance between therapeutic levels for over immunosuppression or for rejection very difficult. This puts them at risk for graft rejection. Therefore, they require a higher dose, which increases the cost of treatment. However, this is outweighed by patients avoiding graft rejection and potential secondary surgeries. Therefore, our goal in the future is to design a preoperative living donor genotyping test, which will allow for the initiation of stratified or personalized tacrolimus dosing schedules at the time of transplant. The feasibility of this is that there's no time restraint prior to transplant, as donors are screened quite extensively before the time of surgery. This would allow us to conduct the PCR and RFLP analysis. Secondly, the financial implications are highly offset by the high cost of liver transplant and the potential risk of future rejection. So although this study was the first in a pediatric liver transplant cohort, it was a single center study with a small sample size. Additionally, concentration dose ratio for tacrolimus represents both hepatic and intestinal metabolism in the recipient, although hepatic metabolism does represent the majority. In future work, other clinically relevant SNPs, such as the function obliterating star 6, star 7, and star 8 SNPs can be analyzed, as well as the effect of the isoenzyme CYP3A4. So in conclusion, whilst aspects of this study have been previously published, this is the first data set in pediatric transplant cohort to have predominant homozygous star 1 expressors, which are prevalent in the African population. The study also included clinical data such as graft to recipient weight ratio and tacrolimus concentration dose ratio. These findings, while preliminary, suggest that a stratified dosing requirement could be developed. This would better inform treatment schedules, especially in Black African patients undergoing solid organ transplantation. I'd like to thank my supervisors, my co-authors, and all the other people that supported me, as well as G2MC for giving me this opportunity to present. And if you have any questions, I'll be next to my poster after this. Thank you very much.
Thank you, Kathleen, for your presentation, excellent presentation. Please excuse me if I'm pronouncing this incorrectly. Next, I would like to invite Hasani Hewavitharana, Ministry of Health, Sri Lanka, to give her presentation.
Good afternoon, everyone, and thank you. My presentation is on the phenotypic and genotypic landscape of a cohort of Sri Lankan individuals with inherited kidney disease. So just a brief background. So monogenic kidney disease refers to diseases caused by rare pathogenic variants in a single gene with a very strong genotypic-phenotypic relationship and very limited environmental influence. So IKDs comprise of more than 150 rare monogenic disorders as one of the most commonest cause of end-stage renal disease after diabetes, hypertension, glomerulonephritis, and pyelonephritis. So more than 600 genes have been known to be implicated with monogenic kidney disease. So coming from a very low resource setting in Sri Lanka, these all burden the health system in Sri Lanka for the need of organ transplantation and long-term palliative care. So it's very imperative that they undergo targeted genetic testing for helping in disease management. So our main objective was to determine this phenotypic and genotypic spectrum. So we did a retrospective observational study at the Human Genetic Unit, the Faculty of Medicine, University of Colombo, over a period of 6 years, where all individuals referred for genetic testing on suspicion of an inherited kidney disease was included. We excluded those with missing phenotypic and genetic data. We used a specialized data collection tool and our digitalized whole exome sequencing database at the HGU. So we found that during this period, 411 individuals were referred for whole exome sequencing and 4% were due to inherited kidney disease. But what was remarkable was that during this study period, almost 80% of the referrals actually came from the last 3 years. So if we look at the diagnostic yield, 16 individuals underwent whole exome sequencing, where we filtered the VEST data based on virtual gene panels relating to the phenotype of the patient, where we were able to do focused genetic data analysis for disease-causing variants. And in the instances where this became negative, we did an exome-wide investigation of the data to increase the diagnostic yield. As you can see, there were 14 individuals with class 3 and 5 variants giving a diagnostic yield of 80%. So if you look at the socio-demographic characteristics, these were mainly male patients, two-thirds. Two-thirds were also of the pediatric population. And Sri Lanka has 9 provinces, with the heavily populated Western province leading the area of residence. 21% were consanguineous and around 36% had a family history of renal disease. So the spectrum of IKDs detected were Gitelman syndrome and Dent disease type 2, with others such as X-linked-Alport syndrome, type 2 renal hyperuricemia, nephrotic syndrome type 2 and 24, X-linked nephrogenic diabetes insipidus, renal glucosuria, and primary hyperoxaluria type 1. So what we saw here was that the clinical diagnosis or the differential diagnosis was matching the genetic diagnosis in 78% of the cases, but the genetic diagnosis was really able to really define the clinical diagnosis based on the subtype and inheritance pattern. So this is just a snippet of the genotypic characteristics we were able to find in this cohort. And just simplified that, we detected 17 variants based on inherited kidney disease. Based on the ACMG guidelines, 10 of them were known disease-causing variants, of which 8 were class 4 and 5, and 7 of them were novel variants, which was quite significant. So looking at the phenotypic characteristics of this cohort, they were mainly Gitelman syndrome patients. So they were adults, mostly female patients, only one of them having consanguinity and family history. And the clinicians were able to diagnose this because of the biochemical features of Gitelman syndrome. And almost all of them had symptoms of electrolyte imbalance. The others, such as Alport syndrome, this was detected in a 19-year-old male. And we were also able to do cascade testing and find 3 carriers in the same family. Den disease type 2 was detected in the very young pediatric population, and they came with a nephrotic range proteinuria. The renal glucoseuria patient had isolated asymptomatic glucoseuria with failure to thrive, and the primary hyperoxaluria type 1 presented with hyperoxaluria detected by urine examination as well as failure to thrive. Hyperuricemia type 2 had symptoms of hyperoxaluria as well as multiple renal calculi, and nephrotic syndrome type 2 and 24 are the spectrum of steroid-resistant nephrotic syndrome. They both came with steroid resistance as well as nephrotic range proteinuria. Nephrogenic DI presented with polyuria, failure to thrive, and their desmopressin challenge test was positive for nephrogenic DI. And we were also able to do cascade testing and detect the mother who was a carrier and a very positive uncle in the maternal side who had the same variant. So the major limitations of this study was that it was single center. It's a relatively short period of time. We studied these patients with a small sample size. We were unable to really find the significance of these variants of uncertain significance because it was beyond the scope. And we were only able to conduct whole exome sequencing. So there was a very likely possibility of missing mutations in introns, copy number variants, trinucleotide repeat expansions, methylation abnormalities, and mutations in exons with low coverage. So we do not do targeted NGS gene panels here, whole genome sequencing, CGS, as well as specific MUCI mode sequencing, and long-range PCR is not done. So we're likely seeing only the tip of the iceberg in relation to IKDs in Sri Lanka. So in conclusion, deep clinical phenotyping and disease-specific genetic testing in a low-resource setting such as Sri Lanka has contributed to high diagnostic yield. Overall genetic testing and subsequent diagnosis of IKD in Sri Lanka shows a rising trend. The significant number of novel variants detected adds to the very unique genetic diversity in the Sri Lankan population, and we greatly benefit from further functional validation studies as well as follow-up for phenotypic evolution. And it further reinforces how important these genetic testing for IKDs is, especially for subtype classification, cascade testing, and to test our potential donors and genetic counseling of mutation carriers. So in the future, maybe these patients can also be eligible to take part in clinical trials and to also benefit from future treatments. So we also, there's a much need to introduce specialized genetic testing in Sri Lanka, because right now it's only based on whole exome sequencing. So it's likely we are not capturing the adult population who have IKDs, especially autosomal dominant polycystic kidney disease, as well as autosomal dominant tubular interstitial kidney disease. So ultimately, these results are actually promoting an awareness, because we really do need a national registry for IKDs in Sri Lanka, which is lacking at the moment. And I think it will be a step in the right direction towards precision nephrology. Thank you very much, G2MC.
Thank you, Hasani, for that excellent presentation. I would like to invite on stage Michelle Kamp from the University of Witwatersrand, South Africa, to make a presentation.
Good afternoon, everyone. Firstly, thank you to the organisers for giving me the opportunity to present at this meeting today. My name is Michelle Kamp, and I'm a PhD student, jointly based at the Sydney Brenner Institute for Molecular Bioscience at the University of the Witwatersrand in Johannesburg and at the SGDP in King's College London. The title of my talk today is Developing an Integrated Risk Score for Cardiovascular Diseases in African Populations. So the rationale behind the project. So cardiovascular diseases are a leading cause of morbidity and mortality globally, but alarmingly, 75% of these deaths occurred in low and middle income regions such as Africa. Importantly, CVDs are preventable, and it's a priority to identify individuals at high risk and get them onto treatment as soon as possible to reduce negative health outcomes. Clinical guidelines advocate risk calculators to identify these individuals, but this remains challenging in Africa, where data is scarce, scores remain largely unvalidated, and they exclude genetics, a known risk factor. Polygenic risk scores can quantify an individual's genetic burden of disease, and usually calculated as the weighted sum of trait-associated alleles. So for each individual, we count the number of risk alleles across all disease-associated variants and weighted by their effect size or their impact. This takes genome-wide information and condenses it into a single estimate of an individual's predisposition for a genetic disorder or for a disorder. We have seen that including polygenic risk scores with traditional conventional risk factors can improve prediction. And this was illustrated by Inu et al. When looking at 480,000 individuals in the UK Biobank and looking at coronary artery disease. So what we see here on the x-axis is the different risk factors, including conventional risk factors such as smoking and body mass index, as well as a meta-GRS, which is the genomic risk score, and combinations of the different factors. And here we see that the genomic risk score is more predictive than any of the individual conventional risk factors. And although not more predictive than these combined, it's important to see here that when we include the polygenic risk score with conventional risk factors, we have the highest level of predictive utility. So these integrated risk scores are gaining momentum and are starting to move into clinical trials in some regions. However, the European ancestry bias in existing polygenic risk scores reduces their transferability across populations and raises concerns around exacerbating health inequities. And just to highlight this, Michelle mentioned this figure earlier, is we see that scores derived in European populations, their prediction accuracy on the y-axis benchmarked at 1 in Europeans, decreases substantially as we increase genetic distance and can be as much as 75% lower in Africans. Saying that, it's not all doom and gloom. We see that there's a growing number of African data sets becoming available that could potentially help remedy this. So saying that, the aim of my project was to derive integrated risk models that's inclusive of genetic and non-genetic factors using data from continental African individuals to predict cardiometabolic traits in Africans. So how did we do this? So the first step is we calculated polygenic risk scores for CVD-associated traits. We looked at 14 traits in particular, those associated with anthropometry, blood pressure, lipids, and liver function. And we did this using the p-value thresholding and LD clumping method and using a publicly available pipeline called GenoPredPipe. Our base data was sorry about the slides. We used the Uganda Genome Resource, which is it contains approximately 14,500 African individuals residing in 5 African countries. Our target data was AWIGEN, or the Africa VITS In-Depth Partnership for Genomic Research, and this is individual level genetic and phenotype data for approximately 10,500 individuals. These individuals reside in Burkina Faso, Ghana, Kenya, and South Africa. And importantly, as you know, with polygenic risk score methodology, these data sets are independent from each other. Next, using regression analyses, we evaluated the associations of these derived polygenic risk scores, as well as selected non-genetic factors, specifically smoking, alcohol consumption, and diet-related variables, as well as physical activity and sleep, with the aforementioned 14 traits, as well as 7 cardiovascular disease-associated outcomes. And then lastly, we derived and evaluated integrated risk prediction models using nested elastic net regression with 10-fold cross-validation. And we looked at 3 models in particular: genetic, non-genetic, and a combination of the 2. So then moving on to results, our first analysis is we assessed the within-trait prediction of our cardiometabolic traits. And what you can see is here on the x-axis, we have our 14 polygenic risk scores, and on the y-axis, phenotypic variance explained, or R-squared, an indication of predictive utility. And you can see here that we saw significant but variable association across our different traits, with the maximum prediction being found in lipid traits, specifically LDL, which was about 6.8%. Next, we looked at the association of our polygenic risk scores with our CVD-associated outcomes. So here we have our 14 polygenic risk scores on the y-axis, and then you can see that we have 7 panels which respond or relate to the 7 CVD outcomes, so namely CVD, dyslipidemia, heart attack, hypertension, obesity, stroke, and type 2 diabetes. We have the log odds ratio on the x-axis for each of these panels, and significant associations are indicated in red. Unfortunately, we only found associations for 3 of these traits, but we believe that this is in part due to small sample size of the remaining traits. Saying that, going forward, my analysis will be restricted to these 3 traits. So next, looking at a similar analysis, we ran regression analyses to look at the association of our non-genetic factors. And here it's a similar graph as previously with our 3 disease traits, but this time on the y-axis, we have our 10 non-genetic factors. And here we can see that there's considerable variance explained by these factors, and so considerable variance explained. So now what we've done is we've shown that there's an association of our genetic factors as well as our non-genetic factors, and we looked to begin as to how we could integrate these two. But the first step, as we saw, is that the association of our genetic scores were relatively small. And so we looked to the literature in ways in which we could potentially improve this prediction. And one of the first approaches was looking if we could create a model which contained all 14 of our polygenic risk scores. So in this graph here, what we have is the 3 disease panels once again, but on the x-axis, we have the 14 polygenic risk scores and their prediction value in purple. And then we have an all model, which is highlighted in pink. And what we saw here is that by creating these multiple PGS models, we substantially improved prediction, so much so we doubled prediction across the 3 different CVD-associated traits. Next, we saw if we could potentially improve this further. And we've seen in the literature recently that if you can incorporate genetic ancestry, you can improve prediction models. And so doing this, using projected principal components from 1,000 genomes, we added in the ancestry predictor, and we could see variable prediction, but in most cases, it improved prediction across our traits. And just to highlight that is the genetic risk scores are in pink, the ancestry in orange, and the combined model is in red. So then lastly, which was the key question of this project, was could we combine genetic risks with conventional risk factors and improve CVD risk stratification in African populations? And so what we did here is the genetic models, which is inclusive of both the polygenic risk scores as well as the ancestry predictor, are shown in red, the non-genetic factors in blue, and the integrated models of genetic and non-genetic in green. And so the first thing we see is that the non-genetic factors account for considerably more variance than the genetic factors, but that when we integrate them, that we can improve prediction, and that polygenic risk scores are giving a complementary and independent signal to prediction. We saw that it increased prediction by approximately 2 to 3% across our traits. And so in future directions, we have to acknowledge that we were restricted by sample size constraints, both in the initial summary statistics we used in our base data, but as well as in our case numbers. And I think moving forward, we're looking at studies which we could include additional cohort data, either from continental Africa, but also looking at multi-ancestry models and utilizing novel methods such as bridge PRS or PRS-CSX. And then, although we did use nested cross-validation to reduce overfitting, we still need to validate these models in external datasets. This is challenging in Africa, where cohorts are unavailable, but it would be interesting to look at the predictive utility of this score across different regional African populations. So in summary, take-home messages are that combining genetic information with traditional non-genetic factors improves prediction performance in African populations, that principal components of ancestry account for considerable variance explained and could be included to improve model performance. And as our models are only ever as good as the data we use to construct them, generating more data and improving access to large African data sets is imperative to improving CVD prediction models in Africans. So with that, I'd just like to say a huge thank you to my supervisors, Professor Michelle Ramsey, Prof. Catherine Lewis, and Dr. Oliver Payne, all of you for listening, and the participants who so generously gave their data. Thank you very much.
Thank you, Marcel. Next, I would like to invite Eduardo Pérez-Palma from Universidad del Desarrollo, Chile.
Hi, I'm putting my timer here. Thank you so much to the organizers for giving me the opportunity to speak to you today about our work. Analysis of genomic data in Chilean pediatric patients with drug-resistant epilepsy. So, first of all, we're based in Santiago, Chile. Here you can see a picture of home office and also the institute, the Laboratory of Clinical Neurogenetics. And if you're never in need of a bioinformatician or a last-minute football player, you can find me here at the fourth row. So, well, throughout the meeting, it has been established that epilepsy has a strong genetic component, especially in those syndromes that has an early onset. So, with this motivation, we gathered a group of interdisciplinary team and started to search for patients with drug-resistant epilepsy and try to identify potential pathogenic variants with exome sequencing. So we aim to evaluate the diagnostic yield of our methods, integrating clinical exome sequencing and bioinformatic methods in Chilean drug-resistant epilepsy patients. So we gathered a pilot cohort of 20 patients from ages from 0 to 18 years old, and especially with previously an unconclusive gene panel testing. So all of these patients were negatives for panel testing, or at least they have reported only VUSs, that is variants of unknown significance. So with these 20 patients, we follow through a standard protocol that included, of course, informed consent and signed by all the requirements by law in our country. And established first, collaborating with the treating doctor and also our own research team, quite the deep REDCap database that was based in previous efforts from other international collaborations. And the filling up this database was done in collaboration between the treating doctors and our own team. So the sequencing was done in the Cologne Center for Genomics in Germany, 70x in depth, and we got from them directly the FASTQ file. So every bioinformatic downstream analysis starting from variant calling was done at our own center. And also after that, we established a lot of bioinformatic criteria, given our own experience, to analyze epilepsy patients. So with that, we gathered around, sat down with our own team and did the variant interpretation, which for each case and each variant looks very much like a trial. So for every variant, we have the case of Mrs. Variant accused to cause the disease of Mrs. Patient. So you have on top of the table evidence for pathogenicity, evidence for neutrality, right? And you have the crime. Did the variant cause the disease on the patient? And this is the question that we try to establish on every case. And we did it for these 20 patients, right? And every variant analyzed. Not all the variants detected, of course, but after filtering criteria, we got a set of suspected variants, right? So an overview of the results of our study can be seen here. So we got 20 patients from a specific place, Clínica Alemana in Santiago de Chile, all with drug-resistant epilepsy and negative panel results. We did the sequencing in collaboration with the Cologne Center for Genomics. We applied, of course, the variant calling, the GATK best practices. And from there, we got around 120,000 variants per patient. Then we applied a set of criteria, filtering criteria by informatic brute force, if you can call it, so to narrow down the 120,000 variants per patient to a set of 4 to 12 candidate gene variants that we got for every patient. And then applying the ACMG guidelines to these candidate variants, we managed to identify 3 pathogenic variants and 9 likely pathogenic variants. The rest of the cases only had VOSs according to our own criteria. So this led to main result, right? The REDCap database, the individual report that the family gets from our own analysis. And also, since we got additional funding, we send some samples to de novo confirmation analyzing the exome of parents. So this is a summary of the table that we got. Of course, the amount of information available is really, really deep. And overall, we identified in 60% of cases likely pathogenic variants and pathogenic variants within our cohort. So, of course, the de novo confirmation will likely change some of the interpretations that we already did, as ACMG guidelines show us that if the variant is present or not in the parents is a strong criteria for clinical significance, right? So what's next? As you know, epilepsy presentation in Latin America is similar, if not higher, than in the rest of the world. So when you take a look at the incidence of the most severe cases, that is developmental epileptic encephalopathies, you can calculate how many cases you can expect by analyzing the rate of mutations that the gene has in the general population, considering the gene size. So the greater size the gene, you can estimate how many pathogenic variants you will get just by chance in a big population. So this is a summary table of how many cases should we expect in Latin America. Just consider that 101 genes associated to developmental epileptic encephalopathies. It's nearly 30,000 cases every year just for Latin America in comparison to the nearly half of them in the United States. And that is because in South America, we have higher rates of natality. So obviously, developmental epileptic encephalopathies are extremely subdiagnosed, so we need to do a lot of more genetic testing, and we're working for it. So with this Epidem pilot project that I just showed you, we managed to increase our access to resources, and now we have another project that it's currently recruited 250 cases. There is a nationwide recruitment effort. And with this, we have also joined larger efforts such as collaboration with Epi25, which is a worldwide collaborative for epilepsy genetic studies. Also, we're working with big databases such as UK Biobank. And following the same procedure, we hope to recruit in the next year 500 cases. And following the same procedure, so analyzing trios this time with a bundled genome exome, which means that we can analyze at the same time common variants and rare variants, and applying bioinformatic methods available in the literature, and also our own filtering criteria to hopefully obtain genetic diagnosis on all the patients recruited. And this picture I saw in one of the Epi25 meetings, one of the largest epilepsy genetic research efforts in the world. And obviously you notice a big gap there in South America, so we're quite proud to put a pin there right now. And well, also since we have this database, we're paying attention to individual cases with interesting genetic variation, but also interesting genetic families. So we hope that we can establish new genotype to phenotype correlations in the future in collaboration with other efforts that we know are out there. And with that, also, we're aggregating everything that we produce. I invite you to check out Evelyn poster and the Chilean population aggregation database that is going to be exposed to be shown soon. And with that, my acknowledgement to all the people that we work, especially to Viviana and Gabriela there that have helped me a lot in this process. So thank you so much.
Thank you, Eduardo, for that brilliant presentation. I would like to invite on stage Taylor Robinson from the National Human Genome Research Institute, National Institutes of Health, USA.
Hi, everyone. Thank you for having me today. I'm really excited to talk about my project, which is with the National Human Genome Research Institute and Georgetown Office of Minority Health and Health Disparities. My talk today is titled Advancing Genomic Literacy, Implementing an Interactive Family Health History Resource in At-Risk Communities. So just a brief outline, I'm going to start by introducing the Family Shared Toolkit, and that is the National Human Genome Research Institute's educational tool. I'm going to then talk about how we expanded this toolkit to the interactive video resource, reviewing the video design, implementation in at-risk communities in DC, and our results. We'll then move to next steps for the video resource, which includes greater implementation in at-risk communities, and follow with the conclusion and future directions for how we can expand this toolkit to broader communities, both within the US and globally. So the Family Shared Toolkit was created by the National Human Genome Research Institute's Social Network and Methods section, and this stands for Families Sharing Health Assessment and Risk Evaluation. And this toolkit hopes to improve genomic literacy by helping individuals learn more about their heritable risk for common complex diseases. And as the name would suggest, we not only want participants to improve their genomic literacy for their own health, but we also want them to have a level of genomic literacy in which they feel comfortable actually talking with their family members and their healthcare provider. So the diseases that we cover are breast cancer, prostate cancer, colorectal cancer, type 2 diabetes, and heart disease. Sorry that it's a little cut off. And it's also currently in 4 languages: English, Spanish, Haitian Creole, and Hausa. So when a participant comes to the Family Share study, they not only receive a Family Share workbook and different worksheets for them to calculate their own risk, but they also receive a personalized family health history tree or pedigree that includes their first and second-degree relatives. They then go on to participate in educational settings that walk them through the workbook so that they can apply this information to their own unique family health history. Through this project, we've also created a curriculum guide so that healthcare students in Florida can actually apply the Family Share workbook to their own community health settings. We've also conducted community education workshops in Washington, D.C., in which those were conducted through focus groups that we realized that participants wanted an interactive and personalized way to learn this information. And that led us to develop the interactive video resource, which I'll be discussing today. So the interactive family health history video is meant to be paired with the physical Family Share workbook, and it's an interactive and personalized resource that participants access through a secure link at our study site. And it goes over the various disease examples that I discussed. There are knowledge checks throughout to ensure that participants are comprehending the information, and individualized next steps so that they can prepare themselves to, again, share and discuss this information with their family and healthcare providers. So the aims of the workbook, the interactive video, are to first introduce family health history. Our participants have a range of knowledge on this, so we want to start them out with this baseline. They can then apply this information to disease risk examples. They can choose up to 3 examples, but they must choose one of the 3 diseases in the workbook. And then they review behavioral recommendations because, as we all know, genetics are just one factor that impact the risk of chronic disease. And then they will create an action plan to, again, ensure that these participants are taking this information and translating it to discussions within their communities. So for the video design, we used a web-based platform known as Qualtrics, which allowed us to standardize how participants viewed this in the pilot study. It's self-paced, so participants can rewind, pause. There may be different interests that they want to grasp before moving on. And so the first part of the video walks participants through the physical workbook that they have. It provides examples, an overview, and future resources. They can then choose multiple diseases and health behaviors to learn more about. And there are integrated questions throughout the survey that allow participants to tailor the education to their specific family health history, their interests, and their knowledge gaps. So for the implementation, our pilot study focused on recruiting Black and African American individuals living in lower income communities in Washington, D.C. And a key aspect of us recruiting these participants, and something that's been talked about a lot today, is the importance of community engagement. So we partner with the Georgetown Lombardi Comprehensive Cancer Center, who actually has patient navigators and researchers who are members of these communities and already have established relationships with these communities, which is integral, especially when you talk about genomics and medical mistrust within the United States. So as you can see, the study site is located in the areas of highest social barriers. This can include access to transportation, access to healthcare appointments, socioeconomic status. And we recruited 20 participants, and 50% of those were men. And this was really integral to the study because in our previous literature, we've seen that men not only have poor health outcomes for these diseases, but they are engaging less in family health history discussions. So by recruiting more men, we can ensure that they can kind of have these discussions within their own communities and talk with other men, given the lack of representation. So the first thing we want to assess is are people actually interacting with the interactive family health history video? And we were happy to see that more than a third of participants actually chose to view 2 or more disease examples. And one reason that may be is because we saw that getting more knowledge questions wrong on the first example they viewed is significantly associated with viewing more subsequent disease examples. And that's illustrated on the figure on the right. And that is showing us that not only are participants potentially aware of their gaps in knowledge, but they're actually using the video to gain higher knowledge by viewing more examples. And I just want to note too that all participants improved on subsequent knowledge checks if they chose to do more. So in that action plan that I was talking about, we asked participants who they can go to for family health history information, and we saw, consistent with the literature again, that the majority of participants can go to older female generations. And this just reaffirms why it's so important in these communities to activate these behaviors within men and address those gaps. And so for our exit interview, we saw that 90% of participants felt more prepared to talk with family members about disease risk, and all participants did plan to talk with their family about the Family Share project. So the next steps for the video, we are currently expanding beyond the pilot version to Spanish-speaking participants in Washington, D.C. who face similar levels of risk. We also are seeing, again, similar results for disease example engagement. So again, a significant portion of the population is choosing to view 2 or more examples. And we're also beginning to distribute the link in this population via email. So participants would actually do this not at the study site unless they chose to, but actually at home. And this is important because we are hoping to improve the video experience so that it can be publicly disseminated. And to do so, we are adding more disease examples, we're diversifying the narrators, we're updating the graphics, and we're adding additional knowledge checks. So for future directions, we are happy to see that this family health history resource seems to improve genomic literacy based on participants' interactions and their action plans. This is integral because when we activate participants' understanding of family health history as a shared commitment to disease, then it can activate within their families cascade genetic testing, conversations about intergenerational health, and they can then talk about it with younger and older generations, and also their healthcare providers who can then provide cascade genetic testing if necessary. And lastly, as the reason that we're all here, we really want to continue expanding this both within the US and the diverse population, but also globally. We have a diverse array of genomic literacy and genomic access, and it's important that genomic advancements focus on that as well. One of our projects that we're currently working on is educating community health workers in Nigeria so that, again, we can have people on the ground who know the community, who are members, who have the rapport and the trust to actually be empowering others in those communities and create a ripple effect that is much greater than I or even my team can do. So thank you to the National Human Genome Research Institute. I know many people couldn't be here. Georgetown and our patient navigators who provide culturally competent care, and of course, G2MC for having me. I'm happy to answer more questions at the end.
Thank you, Taylor, for your wonderful presentation. Moving forward, I would like to invite Annette Uwineza from University of Rwanda. Okay.
So good afternoon again. I'm going to talk about introduction of precision medicine education in medical resident in Rwanda. Genomic medicine importance is increasing in clinical practice that need to require non-genetic medical specialists to expand their expertise. Introducing precision medicine into clinical practice, especially in Africa, is limited by limited knowledge of specialists in genomic medicine. And we identify because that precision medicine should be integrated within residence program educations to address the gap in the skills of physicians to practice genomic medicine. So the University of Rwanda, we have the system of College of Medicine and Health Sciences, where we have the School of Medicine. And the School of Medicine, we have the Center of Human Genetics that has been open since 2006. We have, Rwanda is a small country with 26,000 kilometers square, but we have a population of 13 millions. So we have only 2 medical geneticists, and the medical genetic is taught in the year 3 of undergraduate in general medicine. So as you see, we have a small country, we have populations and limited specialists in human genetics. So we decide to expand the knowledge of precision medicine, especially in residence. So we revised the curriculum of medical residency, and we introduce a course of medical genetics, especially with the content of precision medicine. So we have a system, the University of Rwanda has a modular system, and during the COVID-19, we implemented a model system which allow the e-learning of different students of the University of Rwanda. So we implement that curriculum, and it was uploaded into the modular system. So we have a populations, the first resident to be interested with that precision medicine courses were residents from internal medicine, obstetric and gynecology, anatomical pathology, and dermatology. We designed a course that can be provided online. It was through a blended learning mode, and it means online and face-to-face, and it was providing during 1 month. So the curriculum was developed by 2 medical geneticists and program director of the Rwanda residence programs. Also, during the curriculum development, all program director was involved, but we were only able to teach some residents due to the different conflicting schedule at the University of Rwanda. So the team identified and prioritized the genetic and genomic competency to be included in the curriculum. So the curriculum was composed of 7 topics: fundamental of genetic inheritance, genome structure and functions, clinical application of precision medicine, including monogenetic disease, genetic and complex disease, and cancer, technology of clinical genomic testing and introduction to bioinformatic tools, pharmacogenomics, ethical, legal, and social issues in precision medicine, and the basic genetic counseling skills. So after we developed the curriculum, we provide the curriculum during 1 month, and we do an evaluation of the curriculum. So we design a study that will allow to assess the learner knowledge gained about the key genetic and genomic topics using an e-learning precision medicine short course provided using blended approach on medical residence in Rwanda. We want also to assess the knowledge, attitude, and perception toward the practice of precision medicine among those medical residents. And we wanted to also to evaluate the user experience of this curriculum in resource-limited settings. So the method, we use the quantitative evaluations. We design pre and post-course knowledge of genetic and genomics of residents. They were assessed using 50 pre-validated MCQs. And also we use Lakers scale survey that we allow to evaluate resident attitude, knowledge, and ethical perception toward precision medicine. And another survey that we allow to evaluate the satisfaction of the user experience of this curriculum. So the result, we have, during 2 years, we have 50 participants from 4 different resident programs, and the most frequent resident from internal medicine. But the residents, we have other residents from anatomical pathology, dermatology, internal medicine, obstetric and gynecology. Most of the participants were male, 84%. And during each academic year, we have 25 residents. So the result of our study showed that the resident has improved the knowledge. The resident knowledge assessment showed a learning gain of 48% in pre and post MCQs upon completions. And we identified that before the course, especially students from anatomical pathology or the resident who has most knowledge in precision medicine. Dermatology was the resident who has less knowledge in precision medicine. But internal medicine and obstetric, the knowledge was quite similar. But after the courses, we realized that in most programs, there was acquisition of knowledge. So we evaluate their attitude toward adoption of precision medicine. Unfortunately, we realized that most residents feel that clinical experience is more important than using a patient genetic information to make a decisions. Especially, they found that for them, it's better to use the clinical informations. So they feel the attitude to adoption of precision medicine show that they feel that will be able to identify patients that could benefit from genetic testing. So this survey was done before the courses. So before the courses, they found that they was not very comfortable to identify patients to send from genetic testing. So the knowledge toward genomic testing concepts, most of the residents feel that comfortable to use knowledge about basic genomic testing concept to a moderate extent. So very few, only one student said that he will not able to use the basic genomic testing concept because they already have that courses during the undergraduate studies. So we also wanted to know if they will be comfortable if they have enough knowledge about next generation sequencing. So you see that we have many who say that they don't any knowledge about NGS, and there was those who also say that they don't any knowledge about pharmacogenomics. So it means because most of the students, when they were undergraduate, those concepts were not yet available, or they were not taught during the undergraduate studies. So most of the students found that the course was they were overall satisfied the content of the precision medicine, and they provide the good feedback because as with the pandemic of COVID-19, most of the students identified that there is interesting to implement precision medicine. So we have some challenges because we mixed residents from different specialty. There was some content which are more, you found that are more suitable, for example, for students from obstetric and gynecology, from internal medicine, from dermatology, and maybe we decide that when the next time we'll teach the students separately. We have time constraint from the resident because usually residents are very busy, and we identify that most of the students forget prerequisite of basic sciences. We have to teach all these, for example, they have forget all prerequisite that is required to teach precision medicine. Maybe this is some other activity challenges which are related to low-income country, connectivity issues, because to connect to the modular system is very challenging. And they have also challenged to be enrolled in the model system of the University of Rwanda. So what we learned were to plan ahead of time the course material, because we focus on the theory, but we found that we need to enrich the content with most case discussions and to include, for example, OSCEs for those students. So we have also, we have created other channel of communication, from reminder to attend the courses, for example, group email and WhatsApp groups. So I would like to thank the sponsor of this project, because I did this project when I was enrolled into a fellowship at the International Institute of the FEMA. So thank you very much.
Thank you, Annette, for that interesting paper. Next presentation will be done by Zeina Al-Mahayri, United Arab Emirates University, Abu Dhabi.
Hello, everyone. I want first to thank the G2MC for giving me the chance to be here today and meet all these outstanding experts. So today I will be talking about pharmacogenomics and how can we utilize pharmacogenomic data to prioritize drug choices. And I'll start my talk by a brief introduction to the concept of population pharmacogenomics, moving into the pharmacogenomics research that have been applied in the UAE, and moving into focus into the statins, then ending by the conclusion, how can we use pharmacogenomic data to prioritize or optimize treatment at a population level. So to start with, this is one brief slide about pharmacogenomics and pharmacogenetics, which is the study of variants in our DNA that affect how we respond to drug. So it is actually that to study how genetic variations affect disposition of drugs, or our response or the effect of the drug. So it's either in the pharmacokinetic pathways or the pharmacodynamic pathways. So the goal of this study is to prescribe the right drug for the right patient at the right time, which is the core of precision medicine. So what is population pharmacogenomics? It is that multiple studies have shown that there is different distribution of pharmacogenomic or variants among different populations worldwide. And this is quite controlled by geographic groups. So it's not only the ethnicity and the geography also. So if we get information about special populations, we will be more empowered to find the essential, to stratify which these population according to which drugs will be more effective for them. And this is a graph that I have taken from the paper published in 2022 by Zhou and Lochke that shows the differences in one allele of CYP2C19, a very common metabolic enzyme, and how these are different even in the adjacent countries. So let's look at at the field of population pharmacogenomics. Population pharmacogenomics knowledge of what are the pharmacogene variants that are more common in specific population have shown that is an important resource to give the most effective treatment for this population, which gave the evolution of the concept of precision public health. So now I'll move into the population that I will be focusing on, which is the United Arab Emirates. And for those who don't know what is United Arab Emirates, it's the country that where you can find Dubai, the most famous Dubai. So United Arab Emirates is in the Middle Eastern, is a Middle Eastern country, one of the Gulf countries, and it's populated by a cosmopolitan society. And native Emiratis compose around 11% of the current population of the UAE. Emirates, like any other Arab populations, are very underrepresented in genomic databases. In a report in 2016, in a paper that appeared in Nature, it was entitled, I think it was in diversity in genetics, something like that. It showed that only 0.08% of the whole genomic data, the public available genomic data, comes from Arabs, while this population represents 5% of the worldwide population. So moving into what we have done, and this is part of my PhD project, was how can we investigate the landscape of pharmacogenomic variation in Emiratis, and how does it compare to other populations? So it was done by next generation sequencing of 100 very important pharmacogens that have interact with many important medications. This study, I will show part of the results. There are more than 1,200 genetic variants were detected. Out of these, 140 were novel, and they have predicted in silico to be deteriorating effect on the resulting protein. And of these, the most important finding was that 93% of those healthy Emiratis carry at least one actionable variant that interact with at least one important medication. And this is the list of medications that we have found that they can be not responding well, or they show that adverse effects because of their genetic variants. And most of these were in drugs used for cardiovascular diseases. So from now on, I will be focusing on why don't we focus on cardiovascular diseases for this population. Actually, before that, this study has been published in a scientific report in 2020, and two of its conclusions were that understudied population exhibit different allele frequencies from other, and also they exhibit novel variants, and many of these might be actionable. Also, exploring this variation is essential to improve population drug strategies. So now I'll be focusing on statins. Statins are most prescribed cholesterol-lowering drugs worldwide, and they are used for treating and preventing cardiovascular diseases. And among the UAE population, Emiratis have the high prevalence of cardiovascular disease risk factors in the same compared to other components of the population. And in a report in 2020 by Shihab and colleagues, they found that amongst more than 3,000 Emirati patients who were hospitalized with acute coronary syndromes, and they were all prescribed statins, only 58% of those were actually taking statins. So there's very low adherence to this treatment. And in a more recent report in 2022, it was found that concerns about side effects of statins, and specifically muscle side effects, muscle pain and muscle aches, all are these one of the main concerns of avoiding statins and low adherence of patients to taking these medications. So this, from now on, we thought at this point, why should we not rely on the worldwide evidence of the association between SLC1B1, ABCG2, CYP2C9, which are three of them are pharmacogens, known to interact with statins and known to increase the risk of developing side effects. So we are hypothesizing here that if we find like maybe genotypes with high frequencies affecting these three genes, maybe this will explain to us why this population are more born to a high risk of the side effects, and maybe we can get into a conclusion that these alleles should be tested for this population to increase their adherence to these medications. So we have the whole exome sequencing data of 242 Emiratis, and we extracted the data for these three genes with variants and haplotypes and their predicted, of course, phenotypes. So this is a busy table. I'm not expecting you to see all these numbers, but I'll focus on these three. We can see only focus on the first column, the allele frequencies, and how different from the published allele frequencies from the available public data, because we don't have enough data to refer to Arabs we are really have different allele frequencies compared to all published allele frequencies in the public databases. Also, we composed haplotypes. Again, if we focus on these haplotypes and SLC1B1, which is the main transporter for statins inside the body. So this transporter the function of it is to transport statin to its target site. So if it is not effective, it will be available with high concentration outside of its target site, which is the liver. So it will cause the side effect. So these patients, individuals were carrying these alleles, which are all make loss of function alleles. So at this slide, I'm showing how we accumulated those who have poor function of this transporter, who are composed 5% of our sample, of our cohort, while the intermediate function have around 30% of our cohort. And those, the intermediate and the poor, they will be exposed to a very high risk of muscle pain or muscle symptoms due to after using, if they used high doses of statins, and specific statins that can't be used for these patients. So, and we found that the frequency of poor function SLC1B1 in our cohort was close to the highest reported frequencies worldwide, and the prevalence of the intermediate function is the highest compared to every published allele frequencies worldwide. So this study was among the few that reported SLC1B1 star alleles in Middle Eastern populations and Arab populations. It is the first to use the updated star allele nomenclature for these alleles. For ABCG2, there is one variant that's very well studied and has been associated multiple times with also the side effects of one statin specifically, which is rosuvastatin. But this variant was not very common in our population. It was 0.06 compared to some Asian populations, specifically in Filipinos, which it shows higher, more than 30% of this population. They should start at a half dose rosuvastatin. We didn't see such an observation in our cohort. For CYP2C9, we reported all the star alleles, while commonly CYP2C9 is only the most common alleles are studied, star 2, star 3, and sometimes star 8. Star 8 is added when in African populations, and while most studies, more data is available for these two alleles. We collected all the alleles, and we found, surprisingly, that all the impaired function allele, the common impaired function allele, star 2, which is common in Europeans, is common in has a high frequency in our population. Star 3, which is common in South Asian, in Asian populations, in East Asian populations, is also common in our population. Star 8, which is common in African population, also is present in our population, which proves that we are dealing with an admixed population. Fluvastatin actually is the only statin that is affected with CYP2C9. So this only affects one, not very frequently used statin. But most importantly, CYP2C9 metabolizes a long list of medications and important medications, including warfarin, phenytoin, and many non-steroidal anti-inflammatory drugs. So this finding should increase the vigilance of using these medications for Emiratis.
So also, because we have relied on the agonistic next generation sequencing rather than genotyping the common alleles, we were able to detect rare variants, and the rare variants we detected in both genes were reported previously in sporadic reports and to have effect on statins. So actually rare variants are frequently overlooked in pharmacogenomic commercial panels and are rarely emphasized in studies. But to conclude, we have relatively high frequencies of LC1B1 impaired alleles, which suggest testing these before initiating therapies for this population. And we have found that low percentage will be advised against rosuvastatin, but high percentage should avoid fluvastatin. So detecting rare variants emphasizes the power of next generation sequencing over genotyping, especially for understudied population. And here it's another proof that understudied populations are underutilized reservoirs of human genomic understanding, and understanding pharmacogenomic variants and at the population level can contribute to better strategies for drug prescription. So our future direction is to verify the real-life significance of pharmacogenetic testing before using this medication. And this is what we are doing through the MHeart project, which is the first clinical implementation of pharmacogenomic testing before starting medication for all the components of the UAE population. So, and also we are planning to extend these, or we are extending that same concept to other fields like in psychiatry. So this work won't be done without the support of the funders, and it's done under the supervision of Principal PI, Professor Bassam Ali, and all the team, this work is part of her PhD. And I have to mention also Professor George, who has been for this project since the beginning, and all the collaborators. I would thank you all, and thank you for listening, and sorry for getting more than
Okay, thank you, Zeina, for your interesting presentation. So the last presentation will be done virtually, and it will be done by Nirodhi Dasanayaka from the University of Colombo, Sri Lanka. So Nirodhi, you can start with your presentation. You can start, Nirodhi.
Good evening. I'm Nirodhi Dasanayaka, and my study is about differential expression of inflammatory related genes in healthy long-term meditators. This is a case control study. So I need to let you know first what is meditation. Meditation refers to a set of techniques that are related to Meditation refers to a set of techniques that are focused on maintaining attention on a chosen thought, feeling, sensation, image, phrase, or a posture. It involves paying attention in the present moment non-judgmentally, with an attitude of curiosity, acceptance, kindness, and compassion. It can result in a range of benefits, such as creating a clear, stable, and calm mind, increasing mindfulness, self-awareness, and relaxation. In addition, it affects to our health as well, including the expression of genes related to inflammation. So, inflammation is a critical component of our body's immune response. Previous studies have shown meditation and mindfulness techniques cause detectable changes in the body and mind. But the molecular mechanisms that are responsible for such effects remain poorly understood. So there were several studies which have been done using mindfulness-based techniques such as yoga, qigong, and tai chi. In addition, these studies were focused on a diseased condition such as cancer, obesity, infertility, and depression. So these studies were repeated in different countries with different techniques and found different results. Furthermore, these studies have shown changes that are related to inflammation gene expression after a short period of meditation or mindfulness intervention, which suggests that similar effects can be seen in the long-term meditators as well. So, we aim to investigate the differences in the expression of a selected set of inflammatory-related genes in healthy long-term meditators and non-meditators. So initially, we contacted meditators from meditation centers in Sri Lanka, and then we aligned those meditators with the pre-planned inclusion and exclusion criteria. So the inclusion criteria were like the participants should be above 18 years old, and the meditators who practiced meditation for at least 6 hours per week for the last 3 years were recruited. In addition, we excluded the participants who were with any illness or chronic use of medication, smokers, and the pregnant or breastfeeding women. After the alignment, we screened those meditators using an interviewer-administered questionnaire named Intake Interview to identify skilled meditators. Accordingly, we found 30 long-term skilled meditators, and we then recruited 30 age and gender matched controls using purposive sampling. So, as I described earlier, this is a case control study where we recruited 30 meditators as cases and 30 controls who were age and gender matched. Then we collected blood from those participants and extracted the RNA, and then we synthesized cDNA from those extracted RNA and then performed a real-time PCR. So we chose 8 genes that are related to inflammation: IFN gamma, IL-6, CCL2, CCR7, TNF-alpha, NF-kappa beta, CXCL1, and COX2. So we compared these gene expression data using student t-test, and the relationship between the duration of meditation practice and the expression of genes were done using Pearson correlation. So according to the socio-demographic characteristics, we did not find any significant difference between the meditators and non-meditators, which showed that our meditators and non-meditators were kind of similar. So according to the comparison of the expression of genes related to inflammation between meditators and controls, we found 8 genes which were significantly lowered in meditators compared to the controls. However, 2 genes did not show any kind of significant difference according to the expression of genes. Moving on to the correlation analysis, the relative gene expression of the IFN gamma, IL-6, TNF-alpha, and the NF-kappa beta genes showed significant downregulation with the increasing duration of meditation practice. So, our study findings suggest that the long-term meditation practice could have potential beneficial effects on inflammation-related gene expression. So, these results were consistent with the previously published results. I think the rigorous criteria that we used to identify the skilled meditators and the strict adherence to the inclusion and exclusion criteria may have contributed to the significant results which we got. When we talk about the limitations, the major challenge was addressing the multiple confounders which could affect the outcome variables. And then, actually, our study cannot distinguish the effects of each meditation technique separately because most of the meditators followed 2 or more meditation techniques. As I described earlier, this is a case-control study design which restricts the ability to establish the causal relationships of the findings. So we recommended to do a longitudinal study to confirm the effects of long-term meditation on the expression of genes related to inflammation. So as a conclusion, the significant differential expression observed between meditators and non-meditators indicate that practicing long-term meditation may promote down-regulation in expression of some inflammatory pathway genes that are leading to reduced inflammation in the body. You can contact me using this email address if you have any question. These are my references, and thank you.
Thank you, Nirodhi, for that interesting presentation. And we have come to the end of the podium presentations for the ECI Forum. And big thank you to all the presenters for their excellent presentations. And thank you all for your participation and showing your support to them. So they will be available outside the hall during the networking session, and they will be happy to take any questions that you may have. Thank you.